Hello, everyone. Thanks for joining us. My name is Steve Vanderwall, and I'm the Vice President of Western Canada for Santis Health. We have a great event planned today with an exciting group of panelists who will bring a wide variety of experience and perspectives to our discussion. We have participants from around British Columbia and across the country, and I thank each of you for making time to join us. I'd first like to respectfully recognize and acknowledge the relationship the First Nations, Inuit, and Métis across Canada have with the land that all Canadians live and enjoy. Here in British Columbia, Santis Health carries out its business on the ancestral and unceded homelands of the Coquitlam, Tsleil-Waututh, Musqueam, Squamish, Katzie, Kwantlen, Kikite, and Stalo peoples. We are grateful to these Coast Salish nations for their stewardship and protection, past and present, of the land, water, and air we all rely on. We'll begin the discussion in just a moment, but first I'd like to tell you a little bit about Santis Health. We're a consultancy that offers counsel and supports to clients exclusively in the healthcare, life sciences sectors, and we recently celebrated our 10-year anniversary and launched our Western Canada practice last fall. We offer clients a variety of services that fall under three broad categories. The first is strategy and policy development. This includes services such as environmental scans, needs assessments, system redesign projects, business case development, strategic planning, and change management. Our support helps clients understand the policy environment they're in, identify the challenges they're facing, and the best path forward to achieve their objectives. The second category is communications and stakeholder engagement. This is about supports that help define your message and brand and communicate it effectively to internal or external audiences using various platforms. And finally, we offer government relations and advocacy supports. Our team has deep experience in health policy and government and offers expert counsel on how best to navigate political and policy landscape to advance your issues. If you'd like to learn more about Santis Health and how we may be able to help your organization, please reach out to me or any members of the Santis Health team. Now on to our panelists. I'm thrilled with the panel of experts we brought together today. First, we have Terry Lake, who is the CEO of the BC Care Providers Association and who previously served as British Columbia's Minister of Health from 2013 to 2017. Also joining us is Dr. Lynn Stevenson, who is Associate Deputy Minister in the BC Ministry of Health from 2014 to 2018 and is also a registered nurse. And finally, we're joined by my colleague Daniel Fontaine, who has had a number of senior public and private sector roles over his 25-year career, including more than 7 years as CEO of the BC Care Providers Association, as well as chair of the Canadian Association for Long-Term Care. As I said, my name is Steve Vanderwall, and before my 15 years in public policy and communications consulting, I had the honor of working as a political advisor for 9 years, including advising 3 British Columbia Ministers of Health. On to some housekeeping. We'll get going in just a moment. We want to make this discussion as interactive as possible. And to do that, we need you. Please submit your questions using the Q&A function, and we'll select as many as we can. And afterwards, we're going to send out a survey to all participants and ask you to fill it out and let us know what you think, help us shape future events. Now on to discussion. To start off, I'm going to ask each of our panelists, first Terry, then Lynn, then Daniel, to speak about why change is the new constant in healthcare in BC, and try to keep it just 1 minute so we can get to as many questions as possible. Terry.
Well, thanks, Steve, and great to be here with Daniel and Lynn and all of our participants today. Why is this so topical at the moment? Well, I think we are facing numerous existential threats to our healthcare system in Canada, but particularly in British Columbia. And most of that is around the demographics that we face. We're an older province. We have a lot of people that have chronic complex problems that require a lot from the healthcare system. And unless that part of the population is looked after well, the rest of the system doesn't flow properly. Of course, the demographics are more than just the older part. It's the newer Canadians that are coming here, the people migrating into the province, many of whom don't have primary care practitioners. So this is a critical time in BC's healthcare system, and we really need to look at all of these issues and the system as a whole in order to meet the multiple challenges that we see in front of us at the moment.
Thank you, Terry. Lynn.
Thanks. And like Terry, I'm very pleased to be part of this discussion this morning. I just wanted to dovetail on something that Terry said about the changes that are required, and even our title that changes the new concept. There's always changes in healthcare. I think the skill set now will be to focus some of this change and not change for change sake. Terry mentioned the demographics. I would echo that. One of the things that I would be remiss in not mentioning here in British Columbia in particular, but certainly in this country, is the racism in healthcare. I think that is going to be an enormous personal and professional challenge going forward. And I do think it's something that's getting certainly some traction, but to the point that Terry was making about status and health status, if we don't actually get personally believe serious about this, I think we have an enormous both opportunity but challenges going forward. So I actually think we should not talk about change and look at, so what is it we're going to do that's innovative and sustainable, because we do lots of changes that are not sustainable. So I'll leave it at that, Steve, for right now.
Thanks, Lynn. Daniel.
Thanks as well, Steve, like my colleagues for who've indicated their appreciation for being on the panel today. So in the minute I have, I guess I want to focus on two quick things. One is just around, as we're coming out of COVID-19 and all the changes that our system had to undergo over the last 24 to perhaps 36 months. It'll be very interesting to see where British Columbia goes in terms of perhaps holding on to those changes and then perhaps building on them and moving forward, or perhaps even going backwards in time and seeing if we can go back to a time when we were pre-COVID. So it'll be very interesting to watch that. I'm also looking at, from a British Columbia perspective, the whole new normal around health human resources. And, people are talking about how we're going to be going back to a day where we have we're fully staffed again. And I just don't think we're going to be getting there. And as Terry said, we're in a very unique position in British Columbia in terms of our aging population and the number of people who are coming into the province. So those are the things I'm looking at from a British Columbia perspective, and both pretty critical in terms of our topic today.
Thank you, Daniel. So Terry, our first discussion question, but then I'll welcome the thoughts of others. So we saw COVID stretch the BC health system almost the breaking point in 2020. We also saw decision makers step up and major changes made quickly to adapt to these challenges. Why did it take a pandemic to force these major changes, and which ones do you feel were overdue?
Well, crisis always presents opportunity, Steve. And, the key thing is to not waste a crisis. As much as this was horrible for so many people, particularly in long-term care, it forced us into doing things that we hadn't done before. So recognizing the important work that healthcare aides and other frontline workers do in all of our settings, but particularly for vulnerable British Columbians, was overdue. And so that was good. And the government has indicated they're not going back on that with wage leveling. So that's very good. Increased training opportunities to fill the void of the health human resource challenge that people like Daniel were talking about when I was minister. So, we have to keep our eye on these things that we've recognized during the pandemic, but also innovative things like the greater use of telehealth. I talked to my doctor on the phone probably 3 times during the pandemic, and that's all I needed to do, because when I go in to see my doctor, they're usually not putting their hands on me anyway. It's just Q&A, and I can do that on the phone, and it's just simpler, easier. You can do more visits, and not that it's the exclusive way to do primary health, but we shouldn't go back and force people to march into their doctor's office for every problem, because not every problem requires an office visit, and not every problem requires a physician. Quite frankly, I think we need to use nurse in practice more, and that whole healthcare team, including pharmacists and counselors, and the whole healthcare team, that circle of care. So we've started to do that. I hope we don't fall backwards now that we're coming onto the other side of the pandemic.
Agree completely. Virtual care, using everyone to their scope of practice. Daniel, Lynn, anything to add?
Yeah, if I could just jump in, I heard an interesting story this morning on radio locally about how We've changed the way we've even used our pharmacists, just to build on what Terry said, and how pharmacists can now renew prescriptions, and how they can actually, I think within the next month, they're going to be able to issue prescriptions. So I think that the COVID pandemic really forced us into this change, and it accelerated that change at a pace that would have taken in normal times, perhaps a decade to have happen. And now we're seeing all these changes that have taken place within BC's healthcare system. And some of them are really good. As Terry said, this crisis resulted in some very positive outcomes, and we need to focus on those and say, how can we build more of those types of positive outcomes into the future? We shouldn't have to wait for another pandemic. We should be able to do that within the healthcare system as it stands.
Agreed. I know it's, go ahead, Lynn, sorry.
Sorry, Steve, no, you go ahead.
It's been a while since I was in government, but I heard even 20 years ago about the challenges of technology and privacy, and they were making progress on it. And lo and behold, when the crisis was there, a number of the hurdles were overcome. Go on, Lynn.
I was just going to dovetail on the seniors' care in terms of being vigilant that this actually moves forward in a way that actually meets the needs of seniors. And when I say that, I'm not talking about facilities. I'm talking about the large population of seniors who, as much as possible, want to be independent living. So that whole health community sector, we don't seem to emphasize that. And yet I'm not sure many seniors, and I'm a senior, going to put their hand up and say, I'd really like to go to long-term care. I want to stay in situ as much as possible. So as Terry said, going backwards, I think is something we really are going to need to be careful about, because it's easy to slip back, because there's always going to be other challenges. So I think seniors' health got the attention of this country and this province. Let's make sure that it continues.
And if I could just say, Steve, it's not just the seniors that need care that we're talking about here, it's their family. Because, I'm a senior, but, my parents have both passed, but, now my spouse is dealing with her senior parents. And so many people, in that baby boom era are dealing with aging parents and their caregivers. They're taking time off work. They don't understand the system. They're trying to figure it out. I've got a phone call with a friend of mine after this to help him through that scenario. So, and that impacts the economy. It impacts businesses. It impacts all of our lives. And we are an aging society, but we really haven't come to grips with that. So things like the child benefit have made a great difference to young families, but we don't have a caregiver kind of benefit at the other end that would really take pressure off a lot of families that are dealing with aging relatives that need to be cared for in community and keep them out of long-term care as long as possible. So I just think we can't fix the system unless we're looking at this big wave of the older generation that is starting to need care, but also the people who support them and have to help them figure it out.
And Steve, if I can jump with one final comment, is just, I think coming out of COVID, I think it's important that there's going to be a lot of work, and there has been already a lot of work cataloging what went wrong. I think we have to start cataloging what went right, and actually focus on some of that stuff and say, look what we were able to do in less than 36 months. And give people the tools to be innovative and to say that we can continue with that innovation and that speed of change, and it'll be supported and encouraged in our system versus solely focusing on perhaps how things could have been better or didn't work out as well as people had anticipated. That would be something I think would be a good outcome from COVID. Agreed.
And Terry, a moment ago, you tried to gain sympathy with your panelists by claiming to be a senior. We know that you're young at heart, and after CTME Health Ministry, you gained years back, I'm sure, but no need to claim to be older than you are to gain sympathy from us. So federal health funding, Lynn, the federal government's offering the provinces $46 billion additional funding over 10 years. BC calculates this will be about $600 million per year, far less than the $3.9 billion they were requesting. This includes strings such as new requirements to improve standardized health data. What's your reaction to this health that it'll offer, and what opportunities does it provide to drive real change?
Tough question. And I have to say, when I saw it characterized in the media of just $600 million a year, I thought of some of my colleagues in other ministries in British Columbia who would pretty well kill for $600 million a year. So I think in health, there's never enough. So let's put it like that. I know it fell short of what people wanted. I guess back to the theme that we're talking about, how are we focusing that money? So I don't recall anymore what the, the budget is, but it's over 20 billion for health. Yeah, 600 million is a bit of a drop in the bucket, but surely we should be able to do something with that. I also personally, and this is a personal opinion, am not objecting to the fact there are targets or there are strings. I think as long as they are targets and strings that actually focus on those areas that we just talked about. So look what we just talked about: health, human resources, seniors care, certainly for me, around Indigenous, Métis, Inuit. I think you can actually make these work. And Terry, you and I were involved in many bilateral discussions with the feds. I would say on balance, and I'll be interested in your comments, we got there. It's a grind at times, but I think it is one of those examples that we are a federation, but we're not, in terms of all things are not created equally in terms of population, demographics, those types of things. So never enough. I think it fell short. If I had been still at the ministry, I would do what they did, is take the money and run and see if you can work with focusing that money on your priorities. I don't know, Terry, what you think about some of the experiences we had, which were not that much fun at times.
Yeah, well, it depends how you look at it. They were certainly intriguing. But we made the argument unsuccessfully that the Canada Health transfer should be based on demographics, so that we all know, anyone who works in health knows that it costs way more to look after an older person than a younger person. And so, that seemed to make sense. It wasn't going to fly because Alberta has a young population and Ottawa didn't want to piss off Alberta. So, that's just the politics of it. Now, having said that, there were times where we were getting 6% increases in the Canada Health transfer, but our healthcare budget was only going up 3.5%. So the provincial spending actually wasn't keeping pace. And at the moment, provincial governments generally have greater fiscal capacity than the federal government, because the federal government bailed out everybody through COVID and has put themselves into a harder financial position. So what will be interesting with this new agreement is for us to keep an eye on the provincial health budgets and make sure they're increasing to the same degree as the Canada Health transfer. Otherwise, what they're doing is abdicating responsibility, really, because they've all claimed they need more money for health, but they actually have the greater fiscal capacity, many provinces at the moment, than the federal government. It's never enough money, and there's always things you could be doing better. But if I'm Ottawa and I'm giving money to the province for health, I want to make sure it's being used for health, and particularly for the things that they've agreed on through their bilaterals that are important. So last time it was home and community care and mental health. This time, hopefully, it's long-term care for BC, it's primary care. Those two ends of the spectrum, I think, are in most need at the moment.
And Daniel, any final thoughts before we move on to our next question?
Yeah, just to say that it is rather incredible that $600 million is considered a drop in the bucket, but it really is in the context of our healthcare spending in British Columbia. But I will say that I am pleased that there was an agreement nationally and that we do have a federal provincial agreement. But I'm looking more closely at the bilateral that the province of British Columbia is actually currently underway in terms of negotiation, because I didn't see a lot of commitment, as per our previous discussion, around long-term care and around seniors. That didn't really come out to me as much. But I have heard that the discussions around the bilateral will likely focus a lot more on long-term care. And I think that bodes well for seniors within the province of British Columbia, and to address some of the demographic challenges that British Columbia is unique in facing. So we'll see where that goes. But $600 million never goes as far as you'd like it to go.
Agreed. And just a quick reminder that we do have the chat open and some questions being posted for others. Please put them there and we'll do our best to answer as many as we can. Looking at a question from Charles here. So I'll open this up to who's interested in speaking first. But we continue to hear British Columbians are struggling to access cancer care in a timely manner, with BC lagging behind other provinces in a number of metrics. We know that health human resources is one aspect of this, but how else can BC invest in cancer care in order to address the pressures we're seeing? And what would you like to see included in BC's upcoming 10-year cancer plan? Who'd like to tackle that first?
Yeah, but that, all systems, anyone just has to read about the NHS in the UK right now, understands that the the pressure that COVID presented has set everyone back. And so, and again, with an older population, BC probably would have more cancer incidence than other provinces. So I don't think it's anything systemic about BC Cancer or the way the system is set up here. I think it's a combination of different things. Getting behind in testing, in biopsy results, and in all of the things that are part of the BC Cancer system. Treatment, was tougher, and we lost a lot of people. So I don't think it's a switch that can be flipped. I think it's going to take some concentrated effort on the part of PHSA and BC Cancer and the ministry to get the ship turned around a little bit. But I'm optimistic that within a year, we'll see a lot of those metrics start to turn around, because traditionally, BC has done cancer extremely well. And there's not a lot of things that I've seen that are fundamentally different than they were 5-6 years ago. So I think we hopefully will start to make those improvements.
I'd agree. I think you've got the fundamentals here and have a great system, great plan, great people, but some tough choices ahead as they invest in people, as Charles said, in health and resources, but also in new technologies, some that are expensive that can really offer some great benefits to patients. Daniel, Lynn, any comment?
Yeah,
yes.
I just wanted to add, I think this is a very good example also, though, in broadening our perspective of health human resources, because part of the delay is actually dealing with the screening tests in the lab. So there's, we talk about doctors and nurses frequently when we talk about human resources. A lot of this is about the lab and the ability to run those slides and that. So I think there are some innovations around personnel, but I think there's likely some technological innovations that could be done. And I think that likely will be built into their plan, because I'm not sure they can keep up with our aging population, even if we didn't have this backlog.
Yeah, and I won't repeat what my colleagues have said around health human resources, but obviously it is a critical time for us in British Columbia. And as I keep saying, the new normal is we just are going to have to live with 10 to 15% vacancies. That just wasn't the case maybe 4 or 5 years ago, but that's just the new normal. So we're going to have to adapt, and we're going to have to learn how to deliver quality services with less people. And that's going to take innovation, and that's going to take change in terms of how we do things. But I will say that as we move into the next decade in terms of cancer treatment, I mean, we're seeing some amazing breakthroughs around tailored cancer treatment for the individual versus just for like these broad groups. And I think that scares me in one way because of the cost and how much that will cost for tailored treatment. But I also think that with some of the new therapies and treatments that are coming out, we can actually potentially even lower the cost because of the way we're able to attack cancer within the body on an individual basis. So that is both exciting and a bit frightening at the same time.
Agreed. I have a political science degree, not a real science, but smarter people than me tell me that the economies of scale, as we do more of them and scale it up, that costs a bit cheaper. And you're right, Daniel, some real opportunities to make great strides forward in patient care and outcomes. So Daniel, speaking of health human resources, we're seeing challenges recruiting and retaining staff across the health system. We're talking about that a little bit. Stakeholders calling for action on a number of fronts, including making it easier for professionals from other parts of Canada and those trained internationally to find ways to make it to work here. What else do you think the federal government, provincial government should be doing to help address this HHR crisis?
Well, Steve, I think there's actually probably 5 things that we could be doing on the area of health human resources. And the first one is the crisis. The first one is to treat it like a crisis and not to treat it like anything else but a crisis. We do have a health human resource crisis, and that doesn't mean that we're necessarily going to be able to just recruit a bunch of people right away. We may have to change our procedures, policies, the way we do practices, but treat it like a crisis, like we did with COVID-19, number one. Number two, we have to invest in a lot more training. We just are not investing as a country and as a province in terms of training and making sure people are actually coming out of our educational institutions and are easily able to transition into the workplace, in particular in places like rural BC, which is really, really struggling. Third, I would make and work on the foreign credentials. We are, I can't tell you how many times I've been around in a cab and someone's telling me they were trained as a doctor in England, but they're here, they can't even work as a physician assistant. Those are the kind of things that we need to move on really quickly. Fourth, is something unique in British Columbia. I don't know if it's across Canada, but we actually have a program called the Dual Credit Program, which allows you to train and teach high school students to basically come right out of high school and move right into becoming a PSW or a care aide. We are just definitely not investing in that program enough, and to be able to give the opportunity for young students to get out of school without any debt and go right to work in very well-paying jobs, I think would be really crucial. And lastly, the one thing that bugs me is interprovincial labor mobility. There are more restrictions going from province to province than we have from country to country. We need to really focus on not only getting more money at the provincial and federal level with these bilateral agreements, but start getting agreements on interprovincial mobility of health practitioners. And until we tackle that, all those things, I don't think we're going to be able to really address the issue of health human resources here in BC.
Anyone else care to tackle any of the HHR challenges, opportunities?
Well, I think, we talked about technology a little bit, Steve, and I don't think we are really optimizing technology the way we could. For instance, radiology, and that's got a lot to do with cancer care. When you're looking at CT scans, MRIs, X-rays, why do we have people looking at these anymore with artificial intelligence? And I mean, we surely don't need radiologists spending their time looking at these. I mean, you need radiologists to design the system and make sure you have, checks and balances in place. But I just can't believe in today's world where we do so many things with our devices that we still rely on the fax machine in healthcare so much. So optimizing people, putting them where they're actually needed, and then using technology and artificial intelligence where you don't need a real person. But we're kind of afraid to tackle these things. And also there's a lot of stakeholders, like I'm sure I've got radiologists listening right now who are going a bit crazy. So, no one wants to give up anything when the need for that particular skill isn't perhaps what it used to be. So I think we need a really relevant discussion and just using people at their highest and best use. So, we're doing that a little more with pharmacists now, nurse practitioners, obviously, we've done that over the last number of years. Nurse in practice, we should be doing. People talk about physician assistants, but we have nurse in practice that can do all of that, and they're already trained. And then, providing careers, as Daniel said, a high school student coming out as a healthcare aide, but then providing opportunities to ladder up into an LPN position and maybe further into an RN position. So they actually see a career ahead of them, because not many people want to stay static in one particular job for the next 30 years. That just doesn't happen anymore. So let's provide opportunities for people to move up through the system and optimize and maximize their abilities.
I think the one piece that I would add, Steve, likely is to all of the 5 things that Daniel talked about. There needs to be some metrics around. So how many people do you think you can recruit? How many people can, because, you see announcements, schools announce that they're adding, and I'm making this up, 50 seats. Well, there are going to be 300 people retiring by the time so I get a bit skeptical about the net new that's going to come along this. I think there's this is be an example, I believe quite strong. There's a clear need for policy around how some of this is done, and not leaving it to the regulators, the colleges, and I know, so Terry, if the radiologists are going nuts, I'm sure my colleagues are going nuts too. But to give you one very classic example, we have a national nursing exam in this country, and yet you cannot move from Alberta without going through. So I feel your concern about the internationally educated. I'm more concerned, and I actually had an opportunity to do some work in Alberta, and I could not do it because of the paperwork. And so we get in but I do think there are some metrics around what's the net new going to be out of all these initiatives, because I worry that we're going to have a scattergun approach to this, which we will. And at the end of the day will be at the end of the day. So Daniel, with you, this is a crisis, and this is the opportunity in BC to look at our 23 professions and say, wow, what is everybody doing? To your point, Terry, they're not doing what they could be doing.
And if I could add to one comment from you, Lynn, 100% agree with you. And I failed to mention that in my opening remarks around targets. I really firmly believe you can't just say we're going to train more people without telling people how many you need to train and how many we think we're actually going to be able to train. Because I think we've heard a lot of these announcements, And we're just still feeling like we're going backwards in terms of the health human resources, like we're not moving forward. And a lot of that is, as you said, Lynn, because of the people leaving the system and retiring, and that whole wave that we saw during COVID of people just vacating and leaving the healthcare system. We got a huge crisis that we have to deal with, and we have to treat it like that. So I agree with you 100% on the targets.
And we have to be very truthful about the people who are being trained. For instance, when I was health minister, we opened up more seats at the medical school, and we thought, yeah, we're doing really well. We opened up more residency spaces, but we actually weren't asking the question, who are these new medical graduates, and how are they going to function in the workplace? And these are young people that are going to want to take time out for maternal or paternal benefits. They want to have families, they have a balance of life that's different. And so we thought we were doing really well, but we weren't really being honest about the lifestyle and the work style of the new graduates. So we actually should have doubled or tripled the number of medical school seats in order to make sure that, as Lynn said, with the retirements and the different way that newer physicians are working, that we would still have enough to look after the population. And so that requires being honest about the product of training and what people want in their work lives. And we just kind of went on as if nothing had changed over the years.
Agreed. So maybe we'll bridge now to the new family doctor deal and bridge on a question we had in the chat from David. So we know that the BC government announced in October a new payment model for physicians that adds $700 million and changes the way primary care physicians are paid. However, early reports say that doctors are slow to move over to the new model. We know BC, there's a lot of eyes on BC. I mean, what do members of this panel think? Are you optimistic this will succeed where previous experiments failed? Terry laughs. Always a good sign.
I'm still mad at Kevin Falcon for saying everyone would have a doctor by 2015, and then I took over the file. It's a really tough thing. I mean, just to my last point, physicians work differently than they do today. The style of practice is different. So let's recognize that. I think it's a good step in that it does recognize that, you know, physicians want to work fewer hours. They want to be paid more for a complex patient than a young person that comes in with a relatively simple thing. I remember when I was, in the hospital for a colonoscopy of all things, and the nurse prepping me said, you know, Terry, 30 years ago, patients were so simple, and they're not simple anymore. And so you've got, patients with 4 or 5 complex problems instead of 1 or 2 relatively simple problems. And so you have to build that into the system, either through providing more time for physicians or nurse practitioners to spend with their patients, or by having a circle of care around them so that you can offload some of that care to other parts of the system. And we really haven't focused on that. We haven't used the technology that's available to do that. And so I think, and this used to drive me crazy because staff in the bureaucracy, they were always thwarted by the legislation around privacy that healthcare is hamstrung with. And the Premier's office never thought it was important enough to bring these legislative changes onto the calendar. So you're fighting against, we need more tech positions, so we're going to do that rather than these other things. We really have to focus in health on the HHR and the innovation through technology, and break down the barriers that are there today that we simply haven't had the energy to do to this point. Agreed.
Any other thoughts on the new physician deal?
I'm actually somewhat optimistic, and that's not like me when it comes to physician funding, not wanting to offend our attendants. If nothing else, because it's a change, back to your point, Daniel, it's something different. And when you do something different, and for me, the difference is getting out of the fee-for-service model as the only model to provide care. I think there's merit in actually that in and of itself. And, and I don't mean this the way it sounds, and the money aside. So how will this work? Because Terry's right. This is a different group of people. And with the complexity of the clients that they're seeing now, anyhow, I'm just optimistic that we're doing something different. And back to the, do something a little bit more innovative. I don't know if it's innovative, but I do know it's something different for BC. And so I think all of us are going to watch this with great interest.
And I will perhaps take a bit of a counterpoint and play devil's advocate. I've seen these things come and go over time, where we pour in hundreds of millions of dollars into whatever XYZ, name the pilot project, name the change, and then we just don't see the outcomes that follow as a result of that. So I'm a little bit skeptical. I'm going to be watching it very carefully, but I know that we have, with this agreement with our family docs, have poured in literally hundreds of additional millions of dollars without a single additional hour to be provided. We're merely just changing the way that the formula works and paying some more, and et cetera. But we haven't actually increased the capacity as a result of this funding. So we'll see. The jury's out for me in terms of whether or not this model will be something that will be a panacea or will be able to affect large scale change. But I'm always hopeful. But I'm going to see. I've seen this show before, and it hasn't necessarily delivered the results that we're looking for.
But I guess the important part, Daniel, is what does the show need to show that would actually convince someone? That goes back to the metrics. It goes back to the discussion about the federal funding and having targets. Because you're right, it reminds me of I think, Terry, is when you were minister, where we very proudly talked about home support and how we had increased it, and only to have it pointed out to us we had increased the funding, we hadn't increased the hours. So I think your point is very important, that we need to make sure that we're actually getting some value for the money we're spending.
Well, I'll put myself in an optimistic. I know I have my father-in-law is elderly and had a physician visit last week, and my wife went with him, and the physician spent 40 minutes with him on multiple conditions and spoke through it and the care he was able to get dealing with the person who had that time. I'm unsure if she's part of the new model or just very generous. I suspect that the latter for now, and hopefully this gives that freedom, but that kind of care he was able to get, and which will hopefully reduce his impact in the healthcare system, I think benefits all of us.
And I think, Steve, if I could just add one more comment, I think for your father-in-law, the people who are going to get the care, they're going to get better care. Like, I don't think that's going to be in question. It's the people who don't have family docs, the people who are waiting in queues and have to line up at walk-in clinics in BC, which has the longest wait times in the country for walk-in clinics. It's those people that went back to the point around the capacity and the additional money and being able to give those people access to family docs. I'm not sure this deal has actually dealt with that.
Excellent. I'll have to let him know after this I violated his privacy by discussing his medical issues on an open internet call, but hopefully he'll forgive me. Lynn, you mentioned innovation, and I want to just touch on the role of private sector in healthcare. We've seen Ontario and Alberta be very public about looking to increase the use of private surgical clinics and diagnostics to help reduce wait lists. We saw BC this month repeat in the throne speech that they're going to go a different direction and really look to augment and expand public care and be very critical of that approach, and said that's not the path BC will take in. Maybe I'm interested, what are your views of the opportunities and risks for using private sector for diagnostics and surgical services, either surge capacity or to help reduce wait lists?
I think it's a great question, and it for me is a puzzling question, only because we have private healthcare. And one of, we had a chat, the group of us, as you know, before this. And if you think about the lab services we have, so I think the importance of this question is, what's the question? I think we as Canadians kind of kid ourselves that everything is in the public system. And I'm not suggesting that we go, holeless to a private system, but it exists now. For me, the Achilles heel in moving anything these days is back to Daniel's point about human resources. I believe very strongly that the human resources could be a limitation of this. I also think you need to be cautious about those of us who can pay and will actually then not benefit someone's, for example, like your father-in-law. But I think it's a bit, personally a misnomer that we don't have private care in Canada. And I have to say, I was a bit mystified by Ontario's announcement when I think about what we're doing here in BC. I was trying to get underneath what's the difference, because we have in this province, and Terry, under your watch, and certainly under this government, contracted out many surgical procedures, publicly, funded, so I didn't have to pay. But so I think, Steve, it's an interesting, I think, broader conversation. It's not binary, public or private, because we have private now. It's where does this begin and end? And what are the downsides? And for me right now, and it always was the downside about contracting out the surgical procedures, was the great sucking sound of taking the staff from the public sector, because it's, I guess, better work. One could argue that maybe you should provide better working conditions in the public sector. So I'm not doing a very good job at answering this, because I'm a bit mystified by our puzzle as individuals that we don't think we've got private healthcare. So I don't know, Terry, Daniel, give me a help here.
Well, you're absolutely right. I mean, just off the bat, even if you're thinking about public pay versus private pay, 30% of our system currently is private pay, right? I mean, so dental care, chiropractic, physio, a lot of long-term care. So, and that's why you have extended healthcare plans. So there's that. But even within the 70% that's publicly funded, a lot of it is delivered privately. Most physicians have corporations, and they're private corporations that charge the government for their services. Life Labs is a private company that charges the government for their services. Surgical centers often are used for surge or for CT scans, MRIs, private MRIs, used to help with the wait lists. And so, to me, this is an ideological argument that Canadians fall into as part of their DNA, because there's two things we've always been really proud of: our ability in hockey and our public healthcare system. We found out in the early 70s that our hockey wasn't really as good as we thought when, we went up against the Soviet Union. And really, we keep comparing our healthcare system to the worst one, which is the United States. And so it becomes this binary argument, which is ridiculous. Let's look at high-performing healthcare systems like Australia, like France, like Sweden, like Germany, like Denmark, and then say, what are they doing that we could do here? Instead of saying, oh my God, if we do anything differently, or we have a private stream over here, that we're going to just destroy the public system. It becomes a very, and you can see the certain members of parliament doing that right now in the House of Commons, making it sound like it's a binary argument, and it is not. Put yourself in the patient's shoes and say, how do we give the patient the very best service and the very best choice? Right now, I have friends that are going to Mexico to get their knees done, and they're on Facebook asking where they should go. Because they can't wait here any longer. So there's something wrong with what we're doing, and it boils down to this ridiculous ideological argument that sets Canadians against Canadians instead of putting us in the patient's shoes and trying to figure out a better system. I'll get off my hobby horse there.
And I think, Steve, both Lynn and Terry made good points, and Terry didn't mention it, but this is his life in terms of long-term care. I mean, the long-term care sector, for example, in British Columbia, is primarily privately delivered. It's publicly funded, but privately delivered. And yet most people who go to long-term care in this province, they don't ask when they walk in, is this a publicly funded or a privately funded? They don't ask that. They ask, is there a bed? Am I going to get good care? And what will that care look like? I think just going back to this debate, I don't want to get into this whole two-tier debate because it really is a big one. But what I will say is I kind of chuckled because we did have the pre-meeting, and I said, boy, it would be great to go back to a two-tiered system, because we currently have a 5 to 6-tiered system. If you're on workers' compensation, you get access. If you're wealthy, you can drive down to Washington State, go to Seattle, get any surgery you want within, days. The list goes on and on around the different tiers that we currently have within our healthcare system. So this debate and discussion around whether or not we're going to two-tier is, to me, it's circa 1980s, circa 1990s. We got to move on. And I think that the vast majority of the public are already there, but there perhaps are a few politicians that are still left in another era where people just want to get care. They don't really care so much about who's delivering it. They just want it to be publicly funded if at all possible.
Thanks so much. And again, thank you to those watching and participating. The chat is very vibrant, lots of great questions. I'm sure we can't get to as many. I'll go back to it now. I see a question here related to drug budgets, and especially drugs for rare diseases. And we know that BC's primary care program has one of the most generous income-based drug programs in Canada. but it covered the fewest drugs and is slow to add new drugs recommended by CADIF. And as a result, BC's per capita spend among pharmaceuticals is among the lowest in Canada. And just curious the thoughts of this panel about restricting access to newer therapies might be impacting health outcomes in BC.
Well, it's a really thorny issue for any health minister, because we'd like to think that money is no object when it comes to keeping someone healthy or alive, but unfortunately, that's not the case. So typically, we take recommendations from national bodies that we were part of, and they look at basically the additional benefit per year of life, quality life that this drug will give. And if it's above a certain amount, then it's not likely to be listed. If it's below that amount, it likely will be listed. But it's really, really tough. And we have pharmaceutical companies that will provide patients with the drug for free for a while, and then terminate that and say, okay, government, over to you now. And so it is heartbreaking. It is literally heartbreaking when you see the cost of some of these drugs and looking and having to make a determination. The buck stops with the minister, but bureaucrats and academics do most of the work to determine whether or not this drug is cost effective or not. And we see that going on with Alzheimer's right now. It's a very lively debate about new drugs for Alzheimer's. So, it is tough. Unfortunately, we do ration healthcare because otherwise it would consume all of our tax dollars. And there's no simple answer to it, except we have a system in place. And I just feel badly for people that are on the wrong side of that system.
Daniel or Lynn, any thoughts on the value or risks of increasing drug budgets?
Well, I think Terry captured a lot of what I was thinking. I think it is, it is challenging in a publicly funded system, as Terry said. There are two sides to this, and when you're the one that's waiting for that particular drug therapy, it's incredibly important to your family, to you, to your health. But from a larger, broader perspective, I don't envy people like Terry and other ministers and Lynn who've been in those positions that have to make those critical decisions as to what does and does not get funded. But I think this is going to be, speaking of change and the new concept, this is going to be our new world, because as I said earlier, when you can tailor cancer treatment to the individual, you can imagine the complexities, the ethical challenges that government is going to face in a publicly funded system when an individual could perhaps remain alive if that particular drug therapy was able to be accessible to them. And if it's not, they might die. It's huge challenges. I don't think there's an easy answer to it other than to say that, the more we can increase our economy, the more our larger, revenues are coming into the province, the more fiscally flexible governments are, the higher ability they're going to have to be able to fund this kind of stuff.
I think the only thing, Steve, that I would add to that goes back to our ideological discussion about the private public, is for people to understand that every decision you make on the left hand impacts a decision on the right hand. And I think sometimes that gets lost, but back to Terry, to me, the pharma file was a despairing file, because you just can't do it all. And you can certainly see the opportunities that will not happen if you fund certain things. And this is where, as you know, Terry, the federation falls down, because everybody gets an agreement on whatever. And then PEI, bless their hearts, decides that they will do that. And then it does become political, as opposed to, as Terry said, there's a very, very rigid process around all this, but it is beyond tough. So even seeing that question, I thought, oh boy, it's a hard one.
And Lynn, I didn't add, but I will now, if just I forgot to mention it, is around, I can't remember the exact percentage, but how much healthcare we use in our latter part of our life, like the last 2-3 years of our lives. And speaking of ethical dilemma, like, do you pour a lot of money in to extend, for example, someone's life for an additional 3 months or 6 months or 12 months at the expense of, say, a younger Canadian who's 14, 15, who might need very expensive drug therapy? These are the kind of ethical questions that are going to be challenging. And as we grow and as we age in our population, it's only going to get more challenging.
I'll just add to that, that as we may be reaching the upper end of just the ability to fill spaces with bodies, that equation may have to change. And as you've got the ability to make an investment that may keep people out of a doctor's office, out of a hospital bed, out of the system, that balance and decision may change. But again, hard decisions, luckily smart people are making them and having to balance those finite resources as they look to divide that pie. Maybe one last question. We'll do some wrap-up remarks. Paul Gallant posed a really thoughtful question here, and interesting given the experience that all of you had in the system previously. So in your experience opinion, is any one person directing the change in BC's healthcare system? And if so, are they effectively supporting change? And specifically mentioned the Minister of Health, Deputy Minister, I guess, Associate Deputy Minister, and I'd also say stakeholders as well, who we know play a role in helping to drive decisions internally. Any thoughts on how we're moving forward and who's driving that change? Thoughtful looks. But we know it's a team. We know it's a team.
I'll jump in perhaps first to get it started. I don't think as much as, you know, we have a minister, we have a deputy minister, a bunch of ADMs and other senior executives at the leadership level at the various health authorities. This is a huge beast. It is a large living organism, our healthcare system, and it's got so many moving parts to think that one individual can have somehow some master and kind of leadership role that can affect everything. It's impossible. It really is. The healthcare system is a bunch of small parts that are all connected, kind of like if you're looking at the health example, it's like there's the heart and then there's a lot of veins and different arteries all connected, but it's not one particular individual. It really is a collective. And so I don't see anybody within the BC's healthcare system. I mean, clearly the minister can set the tone and the directive, and the premier can also do that, but it's where the rubber meets the road at the health authority level and at the front line. Does that get translated from thought and concept to practical? I don't know. I think the jury's out on that one.
I would say that what we haven't talked about in this particular webinar is the the whole issue of social determinants of health. And when you think about that, this government, I think, has been progressive in many ways, looking at, income levels and looking at services for people, partnering with the federal government on childcare, things like that. These are things that keep a society more healthy. We need to really focus on mental health and substance use. And so, again, some good things have happened. And the opposition leader is talking about a marked change in the way we address that, looking at more treatment options, to go along with our very strong harm reduction options available in BC. So there are people in British Columbia that are talking about some fairly radical approaches to the inputs of a healthy society. But as Daniel said, it is very, very difficult, and you can't just think of it as one thing. It is so many parts and so many things that impact the health of a person and the health of a society. And so I think we need to think more about those social determinants and think more about mental health, substance use, the trauma that so many Indigenous people have experienced and other people have experienced as well, and how that impacts their health throughout their whole life. And I think there is a lot of conversation going on here in BC about that. So that's a good thing.
Great.
I think I'll just add to that, Steve. I think maybe we should be reversing the discussion about who's actually going to inform these changes, and it just dovetails on what Terry just said. As I think with our Indigenous meeting, they actually inform ways of knowing and being. And certainly, and I hate the word stakeholders, but I'm going to use it. Actually, so if you think about mental health and substance, those are the people that actually can come up with some of the innovations. So I think the more we involve the right people at the right times, which means at the beginning and not when you've actually got a plan and then you could look for afterput, I think the better off we're going to be. And at least you start I think, breaking down some of these binary discussions. It's either this or that, because it's not. It's very mucky and messy.
Great. So I know we're just down to our last few minutes, maybe a last open-ended question. And again, so many great questions in the chat here, better integrated care, making better use of health professionals, better long-term care, better use of virtual care, rural care. But so Lynn, Terry, Daniel, each of you spent a long time in healthcare, overlapping roles. You know the challenges related to stakeholder interests, limits to budgets, technology challenges, privacy challenges. If each of you had a magic wand and the absolute freedom to make a bold change that would make the system truly better, ignoring any stakeholder, budget, technology, legislative challenges, what would it be?
Okay, I'll start this. And I really tried this, but it's hard to do. And that's empower patients. Give them the power of their own information and the power to decide what happens with that information and how that information is used. We all sign up for Facebook and Fitbit and this and that, your Apple Watch, and we just sign away everything. But somehow or other, we're not allowed to own our own medical information. You have to pay a doctor $50 or $70 to get a copy of your medical record if they retire. This is absolutely crazy. We should have that available to us. And we did that during the pandemic. All of a sudden we had this app and you could see every lab test that was done, every prescription you've been on. Like, that was a great leap forward. So we have to take advantage of what's available to us and empower people and their families, because not everyone can make those decisions in their own best interests, as we know. Particularly Daniel and I know this from seniors care. So empower families with the information and give them the ability to access that information and kind of decide how it's used to support their loved ones or support themselves.
And if I can jump in, I'll try to do a little bit of a cheat here. My one wish would have been to fix the health human resource crisis and find a way to address those 5 points that I said, but I'm going to put that aside for a moment. I think if I had a magic wand, the one thing coming out of COVID that for me, I saw so clearly was how we are not focusing enough on mental health. And we are just so lacking in terms of our supports for people who are suffering and living with mental illness in this country, and in particular in British Columbia, and the impacts that that's had in things like the opioid crisis. So for me, if I had a magic wand, I would bring mental health up on the same level as every other component of our healthcare system, and to make sure that it gets the respect it deserves and that it gets the funding that it deserves, and that people can access the type of mental health and drug recovery types of treatment that they just can't do right now. So that would be my one magic wand thing.
And Lynn, last word to you.
I think mine would be public health. I think the big lesson for me, and I think for a lot of my family, friends, et cetera, is who is public health and what do they do when they're doing it? And I think Terry stole a bit of my thunder with his remarks before about the social determinants of health. We pay lip service to that, and yet that actually is, for me, that is the future. And having participated in cuts to public health, and then you reaps what you sows. And I really hope my magic wand would be, let's not forget the absolute critical role they play. And you think of the discussion we've had today, we've talked about private human resources, cancer care. I think until Terry got to his comments, the social determinants. So my magic wand is, let's not forget the strategic importance of public health.
Great. Lynn, Terry, Daniel, thank you so much. Such a great discussion. Thanks to all the participants and the questions. Great discussion. I urge you to please fill out the survey. Let us know how you think. And any questions about Santis Health, please reach out to a member of the team. And thank you all for joining us today, and will not be our last. We'll see you again soon. Thank you.